I'm John Lewis, and today we're going to get a little bit of that cardio in with a little bit of body sculpting. But all around the world, everyone asks me about your abs, the love handles, or the spare tire. I'm going to let you know it's 80% what you eat. So I'm going to show you how to body sculpt them. We're going to take our time, watch the motions, and we're going to learn a lot today. So let's get ready. In 5 seconds, let's get ready to go. Ooh, ooh, let's warm that body up. Ooh, ooh. Come on. Come on now. Okay. There we go. I want you to feel good now. Hey, hey.
Less war, less greed, that's what's missing. Todo problema tiene solución. True love, mucho amor, esa es mi religión. En el hogar de que comienza la educación. Amar al prójimo sin condición en la lección. No tengas miedo, so reach out and give a blessing. No puede ser peor, el mundo está stressing. Muchos están sufriendo y no se lo merecen. Un mundo lleno de humanidad carece.
Y'all know I have to give you those abs. Let's get ready to go. Set up. I need you to lean back. 6, 7, 8, 9, and 10. Other side, nice motions. Hands up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Right leg over, hand in the middle. Go. 1, great. 2, 3, 4, 5, 6, 7, 8, 9, and 10. in. Whoa. Come on now. Chest up. Let's go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, lean back. Point your toe. And go. 1, 2, 3, 4, and 5. Switch sides. Point the toe. 1, 2, 3, 4, and 5. This leg wide. Point the toe. And we're gonna cross. 1, 2, 3, 4, 5. There we go. Open angle, point the toe, and let's go. 1, 2, 3, 4, 5. There we go. We're gonna make a circle. Keep your legs bent. Hold on. 1, 2, 3, 4, and 5. Let's start off wide and circle in. Ready? Let's go. 1, 2, 4, and 5. We're getting a little bit of them hip flexors too. All right. We're gonna lean. Knees up. 1, 2, 3, 4, and 5. Getting a little bit of them quads. Here we go. 1, 2, 3, 4, 5. Let's go. 1, 2, 3, 4, 5. Let's go. 1, 2, 3, 4, 5. Let's go. 1, 2, 3, 4, 5. Here we go. 1, 2, 3, 4, 5. Do it wide. Rock forward. Get that back. 2, 3, 4. Go! Get him up! 5, 4, 3, 2, and 1. Great job, great job. I want to say to you, tell a friend every Tuesday at 2. You not only gonna get some good information from a lot of professional doctors, but also you get to work out with me. So I want to see you next week with a friend, and I'm John Lewis, and see you later. Bye.
Woo! All right. That should have got your heart rate going. And are you a little bit out of breath? Just a little? Well, thanks everyone for joining us. We are so happy to have you guys back. And welcome. Yes, this is BrainTalk Live, because what do? We begin with exercise, because we have to practice what we preach. If we are telling you to exercise and we're not telling you how, shame on us, right? So thank you for your encouragement. Thank you for tuning in. There's about 160 people on, so welcome. I'm going to turn it over to Dr. Monica Parker. She is the director of our Outreach, Recruitment, and Engagement Core and our Minority Engagement Core with the Goizetta Alzheimer's Disease Research Center. So welcome, Dr. Parker.
Good afternoon, Cornelia, and good afternoon to everybody who's chosen to join us today. We have a treat for you today. We're really excited because he asked to come back. We have with us today Dr. Seth Gale, who is part of Harvard University and the Alzheimer's Disease Research Center there. He's going to tell us a little bit more about a different type of dementia, and again, some more about how you can stay healthy and keep your brain healthy. Dr. Gale?
Thank you very much, Dr. Parker. Indeed, I really enjoyed last time being invited to come, and I thought I would share with everyone a slightly different talk. I want to make sure that we have time for questions, so I'll kind of run through this topic. Let me share my screen, and hopefully this will be interesting and helpful. All right, so we're going to talk about non-Alzheimer's disease dementias, and then a little bit about modifiable risk factors, so things that we can do to reduce the risk of dementia at the end. So let's get started. So here's a brief outline of the talk. So I'm going to introduce dementia at large. What is it? What does it mean? What is the facts about it? Who has it? Where? And then overview of how we evaluate them in the clinic. And then to follow on that, I'm going to introduce two patients and go through their stories as was presented to our clinic, and then sort of give you a little inside view of how to think through what is the problem. What symptoms is the person having? How does that make us think about the brain? And then how does that help with diagnosis? And so that's the case-based review. And then, as Dr. Parker said, we'll talk a little bit about some risk factors for dementia, and particularly things that can be modified, things that we can all do, including some of the exercise that we did a couple minutes ago, which was as fun as I recall when I spoke with you all a couple months ago as well. And that's it. And then we'll have some time for questions. So let's get started. So the field, I divided this into two different fields to understand how these symptoms or conditions present, to a health system or a clinic. So there's one discipline or field called behavioral neurology. That's my specialty. So this deals with these various different disorders that are listed here. So neurodegenerative dementias. So Alzheimer's disease is the most common of the neurodegenerative dementias. That is, brain conditions that are progressive and over time, that they get worse over time. And there's other disorders like cognitive and behavioral disorders, that is, disorders that affect behavior and thinking and memory, that are not due to necessarily a progressive problem. It's not going to necessarily get worse, but it's just as impairing in many cases, and it can present to a doctor's office like the center that we have, or the center at Emory. And those include people that have conditions like multiple sclerosis or traumatic brain injury or epilepsy, where the main problem is one of thinking, memory, or behavior. And then there are various medical problems like multiple infections that put someone in the ICU over a period of time, or chronic pain, or autoimmune conditions like rheumatoid arthritis or lupus or Sjogren's disease that have primary cognitive and behavioral complaints. This is the spectrum of the kind of conditions that we can see. And then in the bottom of the slide, you can see neuropsychiatry and geriatric psychiatry. So these are fields where it's mostly psychiatrists or behavioral health providers who are also comfortable with brain structure problems or brain problems. So there's a lot of overlap between these two. And neuropsychiatrists and geriatric psychiatrists are trained as psychiatrists, but then they also have familiarity with neurology, and similar with neurologists who are behavioral neurologists like myself, have a lot of comfortability with helping with mood changes and that sort of thing as well. So what we're going to focus on today is just the neurodegenerative dementias. And I mentioned in the title of the talk that we'll cover in detail the patient stories of two different non-Alzheimer's dementias, so we can get a feel for it. All right, so this table is just to say that typically or classically, as we've understood the brain and these conditions, they can be divided into these two different categories. One is the neurodegenerative, that is that their brain is degenerating over time for reasons that are not clear, that are a subject of research, and then non-neurodegenerative. And these were previously called irreversible and reversible. And I think it's a little bit of a misnomer, because you can bend the curve of decline and not have that precipitous of a decline or to decline that much in some cases. And so it's not totally reversible, for example, for these progressive diseases, but there's a march forward and maybe there's like a plateau sometimes. And then in the non-neurodegenerative cases, just to give some examples of these, people may have heard of like vitamin deficiencies or thyroid problems like low thyroid, hypothyroidism, or B12 deficiency, exposure to toxins like arsenic or stimulant use over time that are theoretically reversible. And again, it's not so simple as reversible or irreversible, but from a doctor's office standpoint, you want to understand and do testing to see if there's changes that you can make, like regulating the thyroid and repleting with vitamins in order to improve some of the cognition or memory problems that the person has. Okay, so with that framework, we come to this term dementia, which many people may have seen this outlined before, but just to bring it back again, dementia is a descriptive term that we use as kind of like an umbrella description. That is that there's a lot of different categories that fall underneath this umbrella. So to say that someone has dementia is really just a description that to say that they have at least 6 months of interference with some aspect of their daily functioning ability due to memory or thinking difficulties or judgment or behavior problems. So it doesn't say that much, it doesn't tell you that much more when we say someone has dementia, or you read about someone that has dementia, because it doesn't describe which disease under the umbrella the person has. So these 5 that are listed here under the umbrella, people may have heard of, and we're going to just briefly talk about 2 of these in more detail today, but I want to give a sense that, so Alzheimer's disease is the most common of dementias in older age, with about 60 or 70% total numbers of all of those who have dementia have Alzheimer's disease. And that has, Alzheimer's disease has a specific finding in the brain. You can find microscopic changes that define that disease. And then probably second is this term vascular dementia, or sometimes if someone has had a large stroke that leads to dementia, it can be called stroke-related dementia or multi-infarct dementia. People may have heard the older term used for this might have been hardening of the arteries if it relates to stroke or small silent strokes. Then there's frontotemporal dementia, which I'll cover in one moment again, but this is not as common as Alzheimer's disease, but common enough that you see it at medical centers like Emory or where we are at Brigham and Women's in Boston. And this is a disease that is often characterized by non-memory changes, mostly behavior change and language change primarily, as well as sometimes motor changes, that is change of muscle tone or rigidity in the arms and legs. Okay, and then there's Lewy body dementia, and people may be familiar with Lewy body dementia from famous people that have had it. For example, Robin Williams, the actor, had Lewy body dementia, and it had, gained popularity in the press during that time and brought awareness to it. Lewy body dementia might be around the 4th most common cause of dementia, and is characterized usually by fluctuations in people's level of attention or level of arousal, their wakefulness. People who have Lewy body dementia very early can have disruptions of sleep in the way that they can act out dreams or talk in their dreams excessively, not the occasional talking in dreams or acting out dreams that everyone can have. And then they can have some impairment in their motor skills. And then there's a whole category of these other dementias, things that are rapidly progressive dementias, dementias related to chronic alcohol use. Listed here is Parkinson's disease dementia. Parkinson's disease is a slowly progressive, usually motor predominant disease first, where people have tremor or gait problems, and then that morphs in can morph into having thinking or memory difficulties. So these are different dementias underneath this umbrella. Okay, and so just a little bit of facts and epidemiology about dementia. So at this point, there's an estimated 7 million people with Alzheimer's disease and related dementias in the United States, and over 50 million people globally. Notably, there's 60% in lower and middle income countries of the total amount. So this affects those countries more than developed countries. And there's somewhere between 15 to 20% of adults older than age 65 have either early stages of one of these dementias, or they have actual impairment in daily functioning. Black Americans are 2 times at higher risk than white Americans, their white counterparts, to have one of these dementias. And Hispanic Americans are 1.5 times have higher risk than their white counterparts in the US. Okay, and then this is an interesting point, I think, that delaying the onset of dementia. So even putting into place exercise, diet, social stimulation, potentially a drug or two, hopefully in the coming years to slow decline. If that's done, even to make a change by a couple of years, the total prevalence, that means at any point in time, the amount of people with dementias in the US or globally can be reduced by almost 50%. So that means that this is an age-related disease. The biggest risk factor for these dementias is age. Even though genetics can contribute and other factors, it's really age that's the highest risk factor. And of course, no one has to be told that the cost, the financial cost and the emotional cost, the personal cost, the family cost of these diseases is just tremendous. These are some numbers to show that by 2050, it'll be over $1 trillion of cost to care for people at end of life, et cetera. Okay, so in the clinical evaluation for dementia that is coming into a doctor's office, whether it's primary care or family practice or neurology like myself, there's a couple of ways to think about what's going on. And this is kind of the backside view of how I would think about, or anyone who's a provider who does this would think about a patient. So one is assessment of people's cognitive and behavioral abilities. So that is to get a status, a sense of where this person is from a thinking and memory standpoint and from a daily functioning or ability standpoint. So this is some of the elements in that. So a detailed clinical interview with specific questions, that is an interview of patients or family members to elicit the information. There's scores on memory testing, specific measures listed here. There are specific tests beyond just those, 30 questions that primary care or someone like myself, a neurologist, would ask, which is, remember these 3 words, copy this shape, etc. There's some specific tests that can help you dig in a little bit to what kind of dementia it is. And then daily functioning ability. If you think about things like driving, cooking, writing checks, getting the mail, taking medications, where is the person doing in each of those, and how does that help to define their degree of severity, basically? And then there's different medical tests or biological markers. So things like imaging of the brain, PET scans of the brain that can be done. These are done in certain circumstances, like the PET scans, or I listed here spinal fluid testing, in certain circumstances where a diagnosis is not clear, and in particular where it may help to define Alzheimer's disease, in which the most detailed biological markers are worked out to this point. That's another piece of information that goes into the equation. So I wanted to give an example of a scale that is used called the Lawton-Brody IEDL scale, just so people can get a sense of how this is tracked over time, how someone's daily functioning is tracked. So there's an examples here in this scale, which is given to a family member or someone who's accompanying someone to a doctor's office. The ability to use a telephone, shopping ability, preparing food, housekeeping, including, and within each of these categories, someone is scored on their current level of functioning, basically, and then there's the scale is tabulated and someone gets a certain score, which kind of helps the provider map out where they are. Mode of transportation, responsibility with their own medications, etc. So there's a total of these 8 measures on this scale. And then I mentioned the brief cognitive screening test. So this is one of the most commonly used ones. People may have heard this in this particular scale before, either in these talks or elsewhere, where again, what you're doing here is you're saying, what are the errors that someone is making? In particular, what kinds of aspects of the brain, whether it's memory or attention or naming, what errors are they making and what things are they getting right? And what that helps to define is where in the brain, what region in the brain there's likely a problem or an early problem in. And this kind of helps put the picture together along with questions that people answer about their daily functioning and what they're having difficulties with, and along with those biological markers or medical tests like a brain scan, blood tests that are looking at vitamin deficiencies and the kind of reversible causes I was talking about earlier. Okay, so to give you a little more a sense of that, this is a very gross breakdown of the brain with the major lobes of the brain and where these certain tasks, mental tasks, and behaviors are mediated, are located. So in the front part of the brain where the frontal lobe is, this is like thought of as the CEO of the brain, the executive of the brain, where you have problem solving and planning. You have vision in the back of the brain where the occipital lobe is. On the side of the brain, near where the temples are coming around, you have the temporal lobe, where memory and emotion and regulation of emotion and memory are mediated. And then you have the parietal lobe, where you have some sense of one's body shape and their own mind and how they move their body in space, for example, to get dressed or to navigate around. So this just gives a sense of how I might be thinking when I see someone or hear someone that says, here's the problem I'm having, or here's what I've observed in my loved one, here's the difficulties. It kind of goes into the whole picture of thinking about the problem. All right, so I'm going to describe a case. I have 2 cases to describe of a patient who came to our clinic and to see me and to walk you through the process of it. So this is case number 1. I call it daughter's graduation. So this was a 68-year-old right-handed man who had changes in behavior, personality, and cognition, or memory and thinking. This was as reported to me by family members over the last 11 months, up to a year prior to seeing me. He was described as always having been introverted, kept to himself, but friends have noted that he had become even more disengaged in conversation. This is the word that they used. His wife thought that he had become less polite. She thought that he was actively listening less in conversations. So he needed some minor help managing his medications, which was unusual for a high-functioning person in their late 60s. Patient himself denied that there was any difference from 1 year ago in any of these. So this is a critical component of this aspect of dementia. I mean, this type of dementia, which we'll get to. He told his wife that he doesn't understand why he has to go to his daughter's high school graduation. He had recently become obsessed with time. He insisted that they go pick up the mail at a local post office box, and he must be there at exactly 10 a.m. every day. And he had difficulty pacing himself through meals. He seemed unable to control his speed through food courses and seemed to ignore clues of satiety or fullness. So again, not much short-term memory observed there, right? There's no real observation of something like forgetting names of people or places or forgetting conversations. So this man had a history of a sudden fainting episode with an arrhythmia of the heart many years prior. He had his appendix out and he had some benign colon polyps. So his family history was pretty normal. He was pretty benign. He was a retired restaurant owner. He had 16 grades of education. He was a non-smoker. He drank about 2 to 3 glasses of wine per week. And he had a family history of late onset Alzheimer's disease that's older than age 65 in his maternal grandmother. And so on his exam, he was awake, he was alert, he was attentive to questions. He did not always maintain direct eye contact. That was notable to me in my notes. He grinned with inappropriate affect at points. So he was really out of the context of the conversation. He was smiling. It didn't seem right to me that in the context of the medical appointment, he seemed restless at times. At one point in this conversation, which I recall was about his family was very concerned about these changes of behavior and thinking, and he seemed restless, and he stood once and just walked over to the window and looked out the window in the middle of the appointment. He displayed some mild word search problems in conversation, so he had a little bit of difficulty with finding words, and he made one minor speech error in conversation where there was a wrong sound at the beginning of one of the words. And he had no evidence of difficulties with visual spatial function or neglect of one side or the other of the room. So on his testing, that's that 30-point scale that I mentioned called the Montreal Cognitive Assessment. His testing was abnormal, but it was in the mild range. So out of 30 points, he scored a 23 out of 30 on that test. The errors that he made were in poor organization. So you have to copy a cube on that test. And he did a poor job in doing that. He didn't organize he didn't have a strategy for doing it. It was just a random lines drawn. He got a point off for not being able to sustain focus or attention on a basic task. That's an attention problem. And then he had another abnormality to highlight was in his higher order thinking. He didn't understand a similarity between two words that I asked him, and he had difficulty with any kind of abstract thinking. So aside from just what we might call concrete thinking, like, what does one do with this tool or something, he couldn't understand abstract thinking, which has you have a concept beyond just the object in front of you. And then he had some interesting answers to questions about judgment. So the question, why should you wash your hands before eating? His response was to get the germs off, which is not unreasonable. The correct answer, the full correct answer is that one has to address that you can spread germs from your hands to your food. From the food to your mouth through your hands. But again, that's not so unusual, but it's not perfectly correct on that scale. And then the other question was, why are certain foods marked with an expiration date? So that's the question. Why do you have an expiration date on foods? And his answer was, you don't want to buy them after. So that's kind of a concrete answer. It doesn't address the fact that they're marked because there's a certain time at which the food goes bad and there's a chance of food spoilage, et cetera, and potentially get sick or something along those lines. So he didn't have judgment or ability to abstractly think outside of what was put in front of him. So when we see a case like this, we're thinking about these different possible types of dementia. And I listed these here just to show that changes of behavior and personality can be seen in a bunch of different mostly rare conditions like vasculitis or like having a tumor in the front part of the brain, et cetera. And then you'll see some other names here like Alzheimer's disease and behavioral variant of frontotemporal dementia and prion diseases as well, which is very rare, but it's the human version of like mad cow disease that people may have heard about. And so for the sake of time, I want to make sure we have time for questions. I want to show you that what was very helpful for this person, he had normal lab testing that showed no abnormalities here. There were some heavy metals that were tested, I think, before he came to see me. That's rarely a cause, but his were normal. And then he had a brain MRI scan. And the brain MRI scan is very helpful to correlate with his behavior and personality changes. So in particular, you can see where the red arrow is here. He had a loss of brain tissue in the front part of the brain, disproportionate to the black areas in the rest of the brain. So disproportionate to the brain volume loss elsewhere and in the temporal parts of the brain. So in the frontal lobe, where you would expect there to be a problem with regulation of behavior, and in the temporal lobes of the brain, where you can have certain aspects of emotion or memory have problems with. So that's very helpful. And you can see here in particular, again, that there's a disproportionate compared to the rest of the brain thinning of the brain tissue with these black spaces. So when you put all of those things together, this is a most characteristic of a condition called frontotemporal dementia. And in particular, he has what is called the behavioral variant of frontotemporal dementia. So different kind of dementia, I think, is the fourth most common in that particular umbrella slide that I showed earlier. And just to show you this condition, this non-Alzheimer's dementia called frontotemporal dementia, broadly speaking, has two different categories. Ones that affect primarily behavior and ones that affect language. And this, again, just to emphasize, this is also a progressive neurological problem that affects more areas of the brain as it goes on, and there aren't any effective treatments yet to reverse or slow the decline. And so of the behavior type of frontotemporal dementia, which he had, there's a more precise term that's used called behavioral variant, or BVFTD. Okay, and just to emphasize this a little bit more, there are criteria, descriptive criteria for what you observe in somebody that support a diagnosis, and someone has to have 3 or more of these A through F descriptions. So loss of early behavioral disinhibition, or the inability to inhibit impulses or behavior, so a kind of impulsivity, early apathy or loss of motivation, significant motivation compared to the person that they were prior, early loss of sympathy or empathy. So an example in this case was, it was just unbelievable that this person didn't understand why he would need to go to his daughter's graduation, right? So this was something that he wasn't going to even go at all. He needed to understand why it was important. So there's a loss of that kind of empathy that's, is natural. Early perseverative, stereotyped, or compulsive or ritualistic behavior. So he had some of that. He insisted on this very unusual thing of going to the post office box exactly at 10 a.m. on a certain day. This became like a rigid ritualistic behavior. So those are some examples of behavioral variant. And this is a little bit more about the breakdown that you can have when you look under the brain microscopically. If people are interested more, you can look into this term called frontotemporal lobar degeneration, or FTLD. This is what you see microscopically in the brain. And it's worth looking at because people might have heard of aphasia, the other type of language part of frontotemporal dementia. We know in the news recently, you may have heard of, like, Bruce Willis had this diagnosis of aphasia. This is really most likely a primary progressive aphasia. That is a progressive neurological problem in the category of frontotemporal dementia. Okay, and so the take-home messages from these is that frontotemporal dementia is disease from symptom onset until severe impairment that can be often shorter than what is more typical for Alzheimer's disease. Doesn't have to be, but it's often shorter. And the leading edge of early signs or symptoms in this condition are behavior, or personality, or language changes. Right? It's not to say that you can't have mood changes and personality and behavior changes with Alzheimer's disease, the most common form of dementia too. That's possible. But there's a certain characteristic of this type of dementia that, and again, meaning that when you look into the brain microscopically, it looks different. It's a different disease than Alzheimer's disease. There's a particular characteristic type of behavior or personality change that's related to loss of insight, awareness, and emotional indifference to the situation. The MRI I described is often frontal and temporal predominant. And I just mentioned that there's some active clinical trials that are looking at different ways to try to intervene, but currently with no successes yet. Okay, and the second case, which I think we can go through, was a 71-year-old, this should say case number 2, I apologize for that. This is a 71-year-old right-handed woman, a homemaker. She had 2 years of subtle forgetfulness when she came to see me. She had difficulty with executing tasks, basic tasks at home, and she self-reported some increased stress. So essentially, some more details. Her family members observed that about 2 years prior to that point that she would forget she heard a story and may even, but would recall them on given reminders. So this is one of the interesting key points that can sometimes differentiate what's going on in the brain. That is that when people benefit from reminders very reliably, that can make you think differently about the problem if you're trying to come up with a diagnosis than if someone cannot benefit from reminders. That is, no matter what, they're just not recalling information. This patient would hear a story and would not recall it immediately, but then when she was given reminders like, remember, it was the store we were at, it was in the afternoon and we were in, outside of the city. Oh yeah, I remember, this is the detail. So she was given cues and reminders and she remembered it. And then in the months following these observations, she and others noticed increasing difficulty executing plans with friends. I think she was gonna meet people. She had a regular meeting where she got lunch or coffee with friends and she couldn't execute. She wasn't arriving. She was missing these appointments. And then there was frequent miscommunication around logistics in general. And she had been careless performing some multiple tasks while cooking. So in 2 prior episodes in the 2 prior months to when she saw me, she either was unable to complete a recipe she was using and she forgot to turn off an electronic pot at home. And generally she felt overwhelmed. This was the stress complaint that she had. So she was generally relatively healthy. She has some osteoarthritis, high cholesterol, some high blood pressure, but generally healthy. She lived alone. She was widowed. She had several adult children in the area who were supportive, also drank a couple times a week of wine. And she functioned independently, again, up until 2 to 3 months ago, even though there were subtle changes going back up to 2 years prior. She just started to lose independence in managing her own appointments and some aspects of her bills that she was paying on her own, the writing checks and things like that at home. So on her exam, where we're getting more information on her thinking and memory, she did okay when you give her 10 words to remember and try to learn. She did better over time. She learned 4 first, then 7, then 6. So it would be better if you learn more in each trial. And then she was able to recall 5 out of the 10, which is not so bad if, she was only reciting out loud that she remembered 7 or 6. And then when she was given reminders, she recognized the words. When she heard the words that she didn't get, she knew all of them. So she had heard these words, she couldn't spontaneously recall them, but when you give her some reminders or cues, they came back to her. And that's an important point for this kind of dementia, and it can differentiate it from what is clearly Alzheimer's disease. And then on a test where you have to go through 1A, 2B, 3C, etc., I'll show you in a moment, she had a really delayed time. It took her a long time to do that test. And I'll show you what that looks like. It's called the trail marking test type B. And people have to, this is put in front of somebody, they're given a pen or a pencil, and they have to start at 1 and go to 1A and draw lines, a line connecting 1A, 2B, 3C, 4D, 5E, etc. And there's a certain time that's expected for certain age. And again, if you do it in a longer time period than you should have by a little or a lot, it can make you think when you're putting together the diagnosis, oh, this person has slowed processing. They understand what the rule is, but it's taking them a lot longer than I would expect it to take over time. And that helps with picturing where in the brain this problem is. So just for time, because I think we're close and I want to actually have time for questions and answers, this person could have significant depression. They could have changes with electrolytes or infection or other derangement in their basic health, which is getting to the brain and causing a problem. They could have small silent strokes or big strokes in the brain that are unknown that are causing vascular cognitive impairment. They could have early Alzheimer's disease. It's less typical. You'd have to look at all the information together, their memory testing, their MRI scan, the observations of symptoms that their family have observed, and put together the best picture that you can. But it's possible that they could have a a type of Alzheimer's disease or a variant that is not the typical short-term memory. And then they could have something like hypothyroidism or low thyroid. This is a questionnaire that asks for people to report and family members to report on agitation or anxiety or delusions or other what we call neuropsychiatric symptoms. So this person had other behavioral symptoms, like they awakened in the middle of the night, rose too early in the morning sometimes, so sleep disruption. I skipped this, but I'll show it quickly. The person was reported as being agitated, mildly, and then their MRI scan was again very revealing in this case. So here's the brain, looking at it, in a cross section, just a slice through the brain. And you can see that this person has a lot of these white changes on top of the gray. So that includes all of these spots here. And it's pretty notable. It's not the most severe, but it's pretty extensive. So we would call this, when you put all the features together, the kind of errors that they made on memory testing, the observations brought by the family members, and the brain MRI scan. Those 3 points make this a vascular cognitive impairment diagnosis. That is memory difficulty that's caused by these small silent strokes in the brain that accumulate over time that you could see on the white matter changes that I showed earlier. So again, that's how things come together to make a diagnosis, by looking at those 3 pieces of information. I think for the sake of time, I will stop here, and I will leave this with this last slide, which I broke up into 2, which is basically what we call, it's a summary from, this is from 2020 in the Lancet Commissions. This was a great report that's really accessible, that you could find online and we could pass around as well. That is modifiable risk factors that relate to dementia risk reduction. So in essence, if you look throughout the lifespan, it's estimated that 40% of dementia cases can be potentially modifiable. That is, that if you recognize things like high blood pressure, hearing loss, depression, significant depression over time, physical inactivity, diabetes, air pollution. I mentioned a number of these on this list, okay? That with addressing these underlying modifiable risk factors, we can reduce the total number of dementia cases. And I think that if to leave with this one thing, this schematic is helpful, just to understand that there's a lot that we can do, and individually and from a public health standpoint, while ongoing research continues for finding effective medications, as BrainTalk Live does, promotion of brain healthy behaviors, as well as addressing things like hearing loss, blood pressure, protecting the brain from concussion and injury, and things listed here. Again, I apologize for time, but this schematic we can pass around. It's really, I think, great to look at. There's a lot that we can do. And so I will stop there, and I thank you for your attention. I'm happy to answer questions.
Thank you so much, Dr. Gale. There are several questions, really more comments, but there's one that's a little intriguing, and it's about, Kathy Rector asks about, why is hand dominance relevant in an evaluation for somebody with dementia?
That's an interesting question. You know, hand dominance can predict, but is not always correlated with language dominance. So if you're right-handed, you're typically left brain or left language dominant. So it helps with that kind of localization. And there are some other tests you can do to establish hand dominance, but that's an interesting question. I would say it's kind of a helpful clue, but it's not that significant in dementia as compared to other neurological conditions.
I have a question. When you are talking to your patients about things that they should do you refer them to, let's say, a nutritionist or a dietitian? to improve their diet. I mean, I'm a primary care doctor and we can pass out sheets and pass out sheets, but in the neurology clinic, what do you do? I mean, a lot of us are a little overweight. I said a little overweight. We're in the South, so we're just a little thick.
Yeah. No, absolutely. So we are trying to, so the short answer is yes. We happen to right now have one dietitian who's interested in aging and dementia risk prevention. We have a program of health coaches that actually take recommendations and meet with people in between visits to say, here's where you are, here's where we're going to get you to. If you're doing 80%, if you're doing 40%, wherever your adherence is to good, healthy eating, these health coaches can do it. But to be honest, as people know, it's hard to implement that across a health system. So we're kind of studying it. But really, I mean, I don't know how setups are exactly elsewhere, but we need many more supportive providers than just the person doing the diagnosis, right? That's 5% of the problem.
Okay, everybody, Dr. Gale's here to answer your questions. Ask. We're going to get you our copy of this program. It's going to be available on our YouTube channel, so you can look at us again on your YouTube channel. But some things that Dr. Gale talked about: eating healthfully, maintaining I won't say ideal body weight, a better body weight, hearing loss, getting those things checked. In the course of a neurologic evaluation and you decide that somebody didn't hear you well, what are some of the things that we can recommend from your perspective?
So basic hearing testing is fairly available, through audiology clinics. Usually it can be done in family practice or primary care initially. Just to piggyback on what Dr. Parker said, hearing loss has been established in the last couple of years as its own independent risk factor. So people who do, and this is a totally modifiable risk factor, people who have untreated hearing loss, that is, if they need aids, they're not wearing aids, it gives less stimulation to the brain, which leads to some downstream effects that are not clear. So that, and also vision. So vision seems so clear sometimes, but we often go for months or years with, oh, my vision is not so great. I've never needed glasses, but I'm now noticing X, Y, Z. There can also be an intervention there, just this simple discussion with whoever you see in healthcare first to start that discussion. Vision and hearing are really underappreciated independent risk factors.
So hear that, everybody? So from part of your annual wellness visit perspective, we need to check our hearing. We need to get an annual eye examination and make sure that we can hear better and see better, right? Somebody
asked Dr. Parker, how do we get a health coach? Based on what I was saying. So this is a really good question. There are many people in many communities who describe and advertise themselves as personal trainers or health coaches. Many of them may be very good. And in fact, there's a certification program, and there might be associated with gyms and community health centers too. There's an interesting certification program happening with health coaching that the American Medical Association has listed as a potential code, that meaning it can be part of the health system. You could be referred to a health coach. That hasn't hit prime time yet, but it's getting there. So they are out there. And I'll say one other thing. A lot of centers, and this is something to talk about again at some point, peer-to-peer health coaching is being studied and is really beneficial for people who want to, help others. They've made changes. That is one of the most powerful ways to motivate people, by seeing the change in others and moving it forward.
I'm answering some of this stuff that's in Q&A. How do you want, if a family wants to get a person evaluated, what's the first step? And I'm about to type it in, but we're going to answer it live. From a primary care perspective, my job is to make sure that everything that's treatable and fixable is addressed. So we check your diabetes, we check your blood pressure, we check your cholesterol. We check to make sure that what you're looking at is not related to the medications you're taking, or maybe an unaddressed or previously undiagnosed mood disorder. And then I will order laboratories like thyroid studies, B12 levels, other studies, thyroid function tests. And if those things are okay, I'll generally order an MRI. And then after that, I will send you to a neurologist. What's your procedure up there at Brigham and Women's, Dr. Gale?
Exactly that. And, some primary care docs, family medicine, geriatricians will do basic memory questions too, to start. It's interesting because like a lot of fields, many people have relationships that are long-term with primary care, and there just are not enough specialists actually. And most care, Dr. Parker will know this, most care for cognitive impairment and dementia is actually done through primary care, and because of the numbers. And so again, awareness, education, intervening on the things we can intervene can actually go a huge distance without a specialized, referral.
Right.
So that's an important point.
And I'm going to take this last one. It says how to make all these testing affordable. Actually, these kinds of evaluations are very affordable. A visit to your primary care doctor isn't any more expensive than going for any other test. Some of the super diagnostic tests like the FDA PET scan, which is not used in routine clinical practice, is very expensive, but a routine clinical examination with your primary care doctor is not any more expensive than any other medical visit that you would have, whatever your Medicare or your insurance copay is. So this is not an expensive evaluation and diagnostic workup.
True.
And okay, I'm gonna leave this point. So I answered that one. Let's see. 3 blood pressure medicines. I don't sleep so well and always in a fog. Is this causing my memory problems? Dr. Gale, I'm going to leave that one with you.
So this point about blood pressure is a good one. So there's been some research in recent years that controlling blood pressure is really important for stabilizing brain health. And in particular, being a little bit more on top of it, getting the numbers down, to the kind of 120, 130 top number, it is, again, it's a goal. And I'll just say one thing, there's been some, you study 1,000 people over time and you follow blood pressure, and actually the tighter that control is, the less of those silent strokes and things that you might find in the brain, which, by the way, when we get older, we all have some degree of. It's just a question of reducing the amount. So a high blood pressure makes people feel foggier and not with it, and that can have long-term effects. So just being connected to a health system and just talking about these things is the first step, including blood pressure.
Okay, and there's one last thing about dentistry. Maybe it's a connection to oral health. Can you address that?
Oh, that's an interesting question. So I think that's true. The press has picked up on particular oral bacteria that might have a causative effect for Alzheimer's, and I think that's a subject of research for sure. The way that I'd interpret this question is oral health is like all health. So people who have infections, in the mouth, that go untreated increases the level of inflammation. It increases, deleterious effects to the brain. That's probably an interesting question to explore, but that my basic response is, as the dentist will say, oral health is as important as all health, and I think that's true.
Yes, and with that, I think we're at an end. Thank you so much, Dr. Gale, for coming back and joining us. And we'll tune in next week. Again, this program, like all of our programs, is going to be available on our YouTube channel, and the link for that is in the chat. And immediately following this, we have the Cognitive Empowerment Program. So thank you to all 212 who joined us, but special thank you to Dr. Gale for giving us his time today. Thank you.
Thank you all. Everyone have a wonderful day. Thanks for inviting me.
Bye-bye.